Good evening, respected Professor Sir and Professor Madam. I and my dear students, I welcome you all for another session of RAISA DNB online academic activities today. We have Dr. Muthumani will be presenting on rheumatic heart disease patient, followed by ASCII discussions today. Over to Dr. Professor Nagaswamy Sir and Professor Vasti Madam and dear students. Dr. Muthumani.
Good evening, sir. Sir, shall I start, sir?
Good evening. Good evening. Go ahead.
Yes, sir. So my case scenario is 21 years old primate with 18 weeks of gestation came with complaints of shortness of breath and mild exertion with a history suggestive of rheumatic fever in childhood, sir.
Okay.
Analysis of this case, primate in early second trimester, rheumatic fever in childhood and symptoms suggestive of grade 3 New York Heart Association classification, sir. History of presenting illness, history of dyspnea for the past 2 days, which is acute in onset, aggravated during routine household activities and relieved by taking rest. History of pedal edema present, no history of orthopnea, no history of paroxysmal nocturnal dyspnea, no history of chest pain, no history of palpitation, no history of syncope, EC fatigability, and cough hemoptysis. No history of cough with expectoration, no history of abdominal distension, right hypochondrial pain, and jaundice. Past history, no history of similar complaints in the past. History of fever with joint pain during her childhood, diagnosed to have rheumatic fever and took treatment for the same and continued treatment for the rheumatic fever. No history of diabetes mellitus, hypertension, tuberculosis, asthma and epilepsy. No history of surgery in the past and no history of dental extraction. Family history. No history of similar illness in the family. Personal history. Not a known case of smoker or alcoholic. Bowel and bladder habits normal. Takes mixed diet. Treatment history. Patient had a treatment history of injection benzathine penicillin 1.2 million units intramuscular injection once every 21 to 28 days. Obstetric history. Pregnancy confirmed at 6 weeks by urine pregnancy test. Buccal and immunized. Number of antenatal visits 2. Coming to the general examination, patient conscious, coherent, and oriented to the time plus person, moderately built and nourished. Her height is 160 centimeter and weight is 60 kg, and her BMI is 23.4. No pallor, no icterus, no cyanosis, no clubbing and lymphadenopathy. Bilateral pitting pedal edema present up to ankle. Vitals, pulse rate 87 per minute, regular in rhythm, felt in all peripheral vessels. No radio radial delay, no radio femoral delay, no pulse deficit. Blood pressure, which is 90, systolic blood pressure of 90 and diastolic blood pressure of 70 millimeter of mercury, measured in left upper limb in sitting position. Respiratory rate, which is 18 per minute. Effort tolerance less than 4 metabolic equivalents. JVP not raised. Temperature normal. Spine and cranium normal. Coming to the airway examination, mouth opening adequate. Malambati grade 2. Thyromental distance greater than 6 centimeter. Neck movements normal. No loose dentures. Examination of cardiovascular system. Inspection. Chest walls shape and symmetry normal. Trachea appears to be in midline. Apical impulse visible in left fifth intercostal place in midclavicular line. No parasternal heave, no precordial bulge, and no dilated veins and scar. Palpation. Tracheal position confirmed in midline. Apical impulse felt in left fifth intercostal space, half an inch medial to midclavicular line, which is tapping in nature, still not palpable. No parasternal heave present. Percussion. Right border corresponds to right border of sternum, left border corresponds to apical impulse. Auscultation in mitral area, loud S1, S2 normal, low pitched grade 3, rough rumbling mid diastolic murmur with opening snap and pre-systolic accentuation, paired with the bell of the stethoscope in left lateral position during the end expiration. Tricuspid area, S1, S2 here normally, aortic area, S1, S2 here normally, pulmonary area, S1, S2 here normally. Respiratory system. Bilateral normal vesicular breath sounds here. No added sounds. CNS, no focal neurological deficit. And summary, 21 years old primate in early second trimester with acquired valvular heart disease, mitral stenosis of rheumatic etiology in normal sinus rhythm, sir.
So from the history, how did you come make out that it should be only the rheumatic stenosis? The case scenario given to you, it says just patient had rheumatic fever. Does it mean that all the patients with rheumatic fever should develop a cardiac problem or a valvular pathology?
No, sir. No, sir.
What percentage of people suffering from rheumatic fever are likely to develop cardiac pathology or valvular problem? Only
3%.
3%. Yeah, only 3% of people who have diagnosed rheumatic fever will develop. Why? Why the 97% even if they develop features of rheumatic fever do not develop a valvular pathology? Anybody else? Because what is the organism causing rheumatic fever?
Group A beta hemolytic streptococcus.
Beta hemolytic streptococcus. So, how does it manifest rheumatic fever? What are the clinical signs and symptoms of rheumatic fever?
So carditis, polyarthralgia.
Immediately when this question is asked, you must say Dr. Jones classification.
John-Stucker's criteria.
Criteria.
Yes,
So,
major criteria are carditis, polyarthralgia, syndrome chorea, erythema marginatum, and subcutaneous nodules, sir. Minor criteria are past history of rheumatic heart disease, fever, arthralgia, prolonged PR and ECG, and increase in ESR and CRP count.
very good. So, how many major and how many minor should the patient have? Confirm that it is a case of rheumatic fever.
So 2 major or 1 major plus 2 minor, sir.
2 minor. Very good. Excellent. So, even if all these things are present, only 3% will develop valvular or cardiac pathology because they should be affected by that particular variety of hemolytic beta hemolytic streptococci which has got a rheumatogenic strain. It affects the gene of the patient. It is a what is the definition of rheumatic fever?
Sir?
What is the definition? How do you define rheumatic fever? Is there any definition for rheumatic fever?
Bonus.
Because in the exam, if you get a case of multiple stenosis, sometimes all the questions will be directed only about rheumatic fever. It is better to learn all the points that you have to answer in the exam. Is it a suppurative disorder? The joint swelling and other things, does it contain any suppurative or pus material? It is a non-suppurative. The definition of rheumatic fever is it is a non-suppurative, self-limiting, immunomediated autoimmune disorder. Okay, that is the definition of rheumatic fever. It is a non-suppurative, self-limiting, immune-mediated autoimmune disorder. Okay, so what is actually the pathophysiology? Why these joints, hearts, and brain, all these things get affected in rheumatic fever?
Because of molecular memory, sir.
Molecular mimicry, not memory. Mimicry. Why it is called molecular mimicry? What exactly is the pathophysiology? How to describe that? See, when a person gets infected with beta hemolytic streptococcus, what is introduced into your body by the bacteria?
Antigens.
Antigen. Very good. So for that antigen, what does the body produce to protect the body?
Antibodies will be produced.
Antibodies. What do these antibodies do? They combine with the antigen and form a complex to reduce their virility and fight with them and destroy them, isn't it? It is the function of antibody. But why should it affect our own tissues to call this as an autoimmune disorder? Why should the antibodies produced against the antigen of the beta hemolytic streptococci affect our own tissues in the joints, heart, brain, and all these structures? What is the reason? Because the antibodies are what are the antigens made up of? What is the biological nature of the antigen? They are nothing but proteins.
Protein.
Okay. They are proteins. So we have proteins which are present in the body which have a similar amino acid sequence. Okay. So the antibodies, they think these amino acid sequence present in our natural cartilaginous structures like joints, heart, and brain, they are also antigens and they start attacking them. That is what is called molecular mimicry. Okay? So the antigens are also made up of protein, and some of our body tissues are also made up of protein, and they possess a similar amino acid sequence. So the antibodies are not able to differentiate between the antigen and our normal tissues and attack both. And then in that bargain, our joints get inflamed, our heart gets affected, our brain gets affected, and all the clinical features of rheumatic fever are exhibited. The form of joint swelling, carditis, Sydenham scoria, brain affection, all these things are because of this. Okay? Are you able to understand, Mr. Mai?
Sir.
Okay. So this is the important thing that you have to know. What about the socio-economic status of this patient? What is the why the socio-economic status is important? Which class of people are affected by rheumatic fever? Is it the well-to-do and affluent people or low socio-economic status patients?
Low socioeconomic status.
Because of lack of hygiene, congestion, so many people living in the same house or small area. These are all the reasons why this thing can easily spread. Okay? So that is how, and lack of nutrition, all these things also play a part in this fever becoming very violent and virulent in these people to cause this problem. Supposing this patient was confirmed case of rheumatic fever, how many years it will take for the symptoms of cardiac involvement come to the fore or be exhibited? What is the normal age group during which the cardiac pathology surfaces after a childhood affect with rheumatic fever? Which decade of life they start developing this problem?
10 years, sir.
10 years post fever, very good, or during the second and third decades of life, okay, from the 20th to 30th year. So this lady being 21 years, ideal age for her to develop all the problems. Okay? So how did he make it is a grade 3 dyspnea? You mentioned that she is suffering from grade 3 dyspnea. How did you decide? What are the various grades of dyspnea? You mentioned New York Heart Association classification also.
Yes, sir.
So what are all the various grades of dyspnea described by NHA?
Class 1,
Hmm.
normal functional status with normal physical activity, sir. No symptoms, sir.
Very good.
Class 2,
Hmm.
slight limitation of functional status, mild symptoms with ordinary physical activity, sir.
Very
Class
good.
3, marked limitation of functional status, moderate symptoms with less than normal ordinary physical activity, sir.
Very
Class
good.
4, symptoms at rest, severe limitation of functional status, sir.
Excellent. Okay. Now you said the patient did not have any history of dental extraction. Isn't it? In your history and description, you said
Yes.
patient did not have any history of dental extraction. What is the importance of that in this case? Why did he ask that history?
Sorry.
Huh?
Subacute back to rule out subacute bacterial endocarditis.
So patient, if they had dental extraction, why should they develop subacute bacterial endocarditis? They go for a dental extraction.
It is a procedure which is involving the mucosas.
Okay. Dental extraction involves mucosa.
Gingiva and
Gingiva. Okay. So in what way it is important? What will happen exactly if they undergo a dental extraction or a urological procedure? What is the risk? Why you should have to worry about SBE, subacute bacterial endocarditis? These are all small pathophysiology you should be aware of, isn't it?
yes, sir.
So if proper antibiotic cover is not given, why should they do a dental extraction? Because there is a caries. Caries means there is an infected tooth. Or if you do some urological procedure like cystoscopy, you are likely to push the commensals or the bacteria that are present there into the bloodstream. And once the bacteria enter the bloodstream, they can go and affect the damaged valves and cause an inflammation, acute inflammation in them, which results in the condition called subacute bacterial endocarditis. So patients with the damaged valve or an altered anatomical structure in the heart should have a prophylaxis for prevention of subacute bacterial endocarditis, and that is the reason you have asked history of. No history is suggestive of dental extraction or any urological procedure. Okay. Okay. Right. Now, what is the normal gradient between the why mitral stenosis starts producing dyspnea in a patient? Why do they become dyspneic if they exert themselves?
So because of pulmonary congestion, sir, back pressure transmission from elevated left atrial pressure is transmitted directly to pulmonary venous system, sir.
Okay, what is the normal gradient between left atrium and left ventricle?
Less than 5 millimeter of mercury, sir.
Less than 5 millimeter. When do they become symptomatic? When will patients start showing symptoms of this, like dyspnea, cough, fatigue, all these things? When will it appear? When what pressure gradient these things will start exhibiting? And how is it graded based on the pressure gradient?
Sir, in mild mitral stenosis, the pressure gradient is 5 millimeter of mercury.
Very
In
good.
moderate, 5 to 10 millimeter of mercury.
Excellent.
And in severe mitral stenosis condition, it will be more than 10 millimeter of mercury, sir.
More than 20 even. Okay.
Yes, sir.
Right. What is the adaptation to prevent this increase in the pressure gradient done by the heart?
Left atrial enlargement will occur, sir.
Excellent. Left atrial enlargement will occur. What is the risk or what is the complication that can be produced by the left atrial enlargement?
Sir, atrial fibrillation, sir.
Atrial fibrillation. What are the types of atrial fibrillation?
Sir, lone AF, paroxysmal AF.
Only two varieties?
Paroxysmal AF, permanent AF.
Paroxysmal, permanent, persistent. These are the three types of AF. Paroxysmal, persistent, permanent. Okay. So what is the risk if a patient develops atrial fibrillation?
Sir, systemic embolism can occur, sir.
First, left atrial and thrombus. That is the first
Yes,
thing. Then it can get propagated and enter either the systemic circulation. Isn't it? So the
Yes,
first
sir.
answer is always left atrial thrombus formation. Why left atrial thrombus formation occurs if the patient develops atrial fibrillation?
Yes, the stasis of blood occurs in left atrium, sir.
Due to turbulent blood flow, there will be a emboli form.
He says persistence of blood, you say turbulent blood flow, which is correct.
Because of
What exactly?
stasis in the left atriums.
There is no effective contraction. The atria are not contracting. When they fibrillate, they are just trickling, they are trembling, they are not contracting forcefully. So there is more a placid stasis of the blood. And with all the inflammatory changes in the endocardium, there is a possibility that the thrombus can form. There is a, unless the blood keeps circulating, all the procoagulant factors can be deposited. That is, last platelet will go, then it will get adhered to the subendothelial matrix, then it will start attracting more platelets, and slowly the thrombus will form. Which part of the atrium you will first develop the thrombus?
Appendage, left atrial appendage, sir.
Left atrial appendage, and that is the why is there. That is the common site for development of the thrombus. Why not it develop in the cavity of the left atrium? Why it always develops in the left atrial appendage? Because even in normal atrium, that is the least contracting part, because it is only an appendage, So that is the least contractile portion of the atrium. And when the atrium stretches, it becomes even more immobile. And that is the reason why you develop the thrombus in the left atrial appendage, which propagates and then starts entering into the cavity, and it sometimes even occupies the entire left atrial chamber. Okay, so that is the first risk of atrial fibrillation. What else? What are the other risks of atrial fibrillation?
Pulmonary edema, sir.
It will aggravate congestion, it will cause pulmonary edema. Okay, so these are the two important dangerous complications. So the thrombus formation and embolism and stroke, the very slow progressing complication. Whereas acute pulmonary edema is a very life-threatening complication in a patient with a severe narrowing of the mitral orifice. So what is the normal size of a mitral valve?
4 to 6 centimeters square, sir.
4 to 6 centimeters. What are the various grades of narrowing?
Sir, sorry, sir.
What are the various grades of mitral stenosis or narrowing of the
Yes, sir.
mitral valve?
Sir, mild, moderate, severe, and critical, sir.
Critical.
Mild 1.5 to 2 centimeters square. Moderate 1 to 1.5 centimeters square. Severe less than 1 centimeter square. Critical less than 0.5 centimeters square.
0.6 centimeters square. Very good. So these are all the various grades. Okay? So if a patient without knowing when she is asymptomatic, she gets married and immediately becomes pregnant. Why they start becoming symptomatic after they become pregnant? Patient who was
Because of
asymptomatic.
physiological changes occurs in pregnancy, sir.
Very good. What are the physiological changes which exacerbate the symptoms of mitral stenosis?
Sir, increase in central blood volume by 45 to 50%, sir.
Very good.
Increase in heart rate by 15 to 20%, sir.
Very good.
Increase in cardiac output by 40 to 50%, sir. It begins to increase by 5th week and becomes maximum by 32th week of gestation, 37th week of gestation, sir.
Okay. So these cardiovascular changes that happen in pregnancy, why do they exacerbate or bring forth the occult or hidden mitral stenosis in a patient? See, this lady probably she did not know she has a mitral stenosis. She got
Yes,
married, she has become pregnant. Now from the 18th week of pregnancy, she has started becoming dyspneic. Why these changes occur? Because now you make a diagnosis of mitral stenosis. Why the normal physiological changes are affecting a patient with mitral stenosis? The answer is easy. You have been nicely describing everything. There is a narrowing of the valve. When the volume increases, will it be able to pump it from the left atrium into the left ventricle to increase the cardiac output?
Yes, sir.
Yes, sir. Mitral stenosis will it be doing that? It will not be, isn't it? When the valve is narrowed, the normal flow from the left atrium to left ventricle is not happening. So, but the volume of blood, because of the increase that happens during normal pregnancy, is happening already. So the heart is not able to push all the blood that is received by the left atrium to the left ventricle. So there is always a pulmonary congestion, as you said, and pulmonary hypertension also develops. That will make the patient develop the dyspnea. Okay. So what is the problem in the reduced left ventricular filling? In what way it can affect our pregnancy?
There will be reduced cardiac output, sir.
Very good. There is a reduced cardiac output. That way, what is the risk involved?
Oxygen demand will be increased, sir, for both fetus
Oxygen
and mother.
demand is not supplied. Oxygen demand is not increased adequate unless you have adequate cardiac output. It cannot supply oxygen both to the mother's need as well as the fetus need. So what is the risk to the fetus?
Growth retardation.
Intrauterine growth
Growth
retardation.
retardation.
And will the mother be brisk and active?
Premature delivery, stillbirth, sir.
Okay, that's also another risk. What happens in the mother? What will be the earliest complaint of a mother with mitral stenosis when they become
Easy
pregnant?
fatigability, sir.
Easy fatigability. Now there are again cardiac output is not adequate and tissue oxygenation is not adequate. That makes all the muscles suffer from hypoxia. So they get tired and fatigued. Okay. So it will affect both the mother as well as the fetus, and we have to be very watchful in that. Right. If supposing it is a mild mitral stenosis, okay, the orifice, as you said, is only 2.5 centimeters instead of the normal 4 to 6 centimeters square. And patient is having mild dyspnea. How to manage this patient? Sorry.
I
What
would
is
like
the
to
treatment?
investigate further, sir, with the investigations such as ECG, chest X-ray, and 2D echocardiography, sir.
Okay. Hmm. So all this investigation, ultimately you are going to treat the patient, isn't it? I'm asking
Yes,
about the treatment for the cardiac condition, not as a whole. The mild
Diuretics
Hmm.
diuretics added to relieve the congestive symptom. For
Okay.
rate control, calcium channel blockers or beta blockers can be used.
Hmm.
In case of atrial fibrillation, anticoagulants can be used, sir.
Hmm. Now, when will you give an anticoagulant in a patient with atrial fibrillation? What is the time interval at which you should start administering anticoagulant? Is it any patient? Supposing this patient develops atrial fibrillation only today, will you start anticoagulation today itself, or do you have to wait and then give the anticoagulation a little later? This is the time
Wait and
criteria
give.
for starting anticoagulation. Hmm. See, this is only logical thinking. In the patient who develops atrial fibrillation, will they immediately develop a big thrombus?
No, sir.
How many days or hours or months it will take to develop a thrombus after the first episode of atrial fibrillation? It takes only minimum 48 hours to form the thrombus. Okay?
Okay, sir.
So before 48 hours, nobody will develop a huge thrombus which can get disseminated and then become an embolus. So up to 48 hours, you have to plan only reverting the atrial fibrillation to normal sinus rhythm and control the heart rate. Okay. Beyond 48 hours, if the atrial fibrillation persists, then only you have to start anticoagulation therapy. Okay. This should have a very clear thinking and concept. So what are the goals in the treatment of atrial fibrillation?
Sir, atrial fibrillation, sir.
What is your goal in the treatment of atrial fibrillation? What are all the goals you have to keep in mind for treating atrial fibrillation?
Preload, afterload, contractility, rate, rhythm, systemic vascular resistance, and peripheral vascular, pulmonary vascular resistance.
No. I am asking only about the treatment of atrial fibrillation, not the management of a patient coming for anesthesia for any surgical procedure.
Rate and rhythm control.
Rate, rhythm, anticoagulation. These are the three pillars of treatment. Rate control, especially ventricular rate control, rhythm reversion to sinus rhythm, anticoagulation. These are the three pillars of treatment of atrial fibrillation. It may be a patient with pregnancy. What are all the other causes of atrial fibrillation? Will only mitral stenosis cause atrial fibrillation, or other causes are there for
Thyroid. Hyperthyroidism, sir.
hyperthyroidism or hypothyroidism?
Hyper, sir.
Okay.
Hyper.
Hyperthyroidism is another
Sepsis
reason.
can cause atrial fibrillations.
Huh?
Sepsis, septic foci.
Septic foci will not cause atrial fibrillation. Do you know the
Left atrial
mnemonic
thrombus.
ARIT.
Left atrial thrombus.
Left atrial thrombus is a sequence of atrial fibrillation. It is not the cause of atrial fibrillation. It is a result of atrial fibrillation. Can alcoholism produce atrial fibrillation?
Yes, sir. Holiday hearts.
Can ASD produce atrial fibrillation?
Yes, sir.
Can rheumatism, rheumatic fever by itself can cause atrial fibrillation?
Yes.
Okay, so there are both cardiac, non-cardiac conditions or causes for atrial fibrillation. Even long-standing lung infection can produce atrial fibrillation. Okay, so these are the three important steps in the treatment. So how do you convert the atrial fibrillation back to sinus rhythm? Examiners, they expect you to know all about management of atrial fibrillation because it's one of the important complications in the acute care settings, critical care settings. Patient can suddenly develop this problem. So, how to treat a patient who has developed atrial fibrillation with a ventricular rate of say 150? What will be the atrial rate if the patient develops atrial fibrillation and the ventricle shows a rate of 150? What will be the atrial rate? Will it be the same or will it be more or less?
It will be more, sir.
More, sir.
Yeah, it has to be more because
Yes, sir.
always the sinus node produces a higher rate even in normal. What is the normal pacemaker rate?
60 to 100.
100 to 120. But what is your normal heart rate?
60 to
70
80.
to 90. Okay, so there is a loss from the higher rate at the pacemaker during the conduction. Similarly, atrial fibrillation produces the atrial rate even up to 450 to 500. But what will be conducted to the left ventricle will be much less, and you will have a ventricular rate of anywhere between 120 to 150. So our aim is to get back the normal ventricular rate. That is number one. Then number two, we have to get back to the sinus rhythm. So how do you identify atrial fibrillation? What is the investigation which will tell you that the patient is in atrial fibrillation, and what is the clinical picture to diagnose atrial fibrillation?
Irregular rhythms.
Irregularly
ECG.
irregular pulse. Excellent. A simple pulse examination will tell you that there is an irregularly irregular pulse. Any other clinical test you have to do?
Sir, apex pulse deficit will
Pulse deficit. It is not effects pulse deficit. You have to identify the pulse deficit. How do you test for pulse deficit?
So by placing stethoscope over the
You
apical
need
region.
persons or you can yourself do it.
So myself, he will do it.
A single person can find out the pulse deficit. You can auscultate and count the heart rate. At the same time, you can count the pulse rate also by holding it. Both you can count at the correctly by the same time. Eh?
We need two persons.
You need one person to auscultate and count the heart rate, and you need another person to hold the pulse and count the pulse rate. Okay, and the person auscultating will have a higher rate because the actual rate is more, heartbeat will be more, but the number of pulses conducted peripherally will be less, so the person counting the pulse at the radial will be having a lesser number. So this difference between the heartbeat and the pulse beat known as pulse deficit. Supposing you don't have any help, you are a single person, can you find out pulse deficit?
ECG monitors.
ECG monitor. Any other simple instrument with which you can?
Pulse ox.
Pulse oximeter, excellent. So if you put a pulse oximeter probe, it is going to tell the pulse rate, and you can auscultate and count the heart rate. And then for 1 minute you can do that and then find out the difference. So nowadays with the availability of finger probe pulse oximeter, after COVID, every house, every person is having a finger probe pulse oximeter. So if that simple instrument is there, even without a second person's help, you can find out the pulse deficit. What is the objective confirmatory evidence of atrial fibrillation? This irregular pulse and pulse deficit are clinical examinations of atrial fibrillation. But if you want a documented evidence, how will you?
ECG, sir.
ECG.
You have to take an ECG. Excellent. So you take an ECG, you automatically show the fibrillatory waves, and you can easily find out. Will there be a P wave after every QRS complex?
No, sir.
No, sir, absent PV.
There will be rapid atrial wave, then there will be followed by a QRS without a proper P wave, and it will be again irregular. So how will you calculate the rate if the patient is in atrial fibrillation using the ECG? One of the ASCII questions.
Number of QRs.
Normally we take the adjacent QRS, I mean the R waves, and try to see whether it's a small square or big square, isn't it? That is how we calculate the rate. Think about it and tell me before the class. Right. So second thing is reversion to. So how do you revert the patient back to sinus rhythm? I'm spending more time on this because it's a very commonly asked question in the examination. You must know how to treat an atrial fibrillation and get the patient back to sinus rhythm.
Synchronized cardioversion.
Synchronized cardioversion immediately, or is there any? You can classify it into pharmacological.
Depends on whether patient. Depends on whether patient is hemodynamically stable or unstable.
Stable or unstable. Excellent. That is the first and foremost. If the patient is hemodynamically unstable, then the cardioversion is the treatment of choice. So how do you do the cardioversion? Is any anesthesia needed for cardioversion?
So we have to sedate the patient.
Sedation. Mild sedation.
Mild sedation. Sometimes even in a very anxious patient, restless patient, if they are hemodynamically unstable and they are in hypoxia, they will not be sedated. If you give just a sedation, so you may have to give full induction dose of induction agents. To make sure that they are not in full stomach, be prepared for securing the airway at any time. Keep all the emergency drugs ready and you do the cardioversion. What is the difference between cardioversion and defibrillation?
That is synchronized and
Refract absolute.
defibrillation is desynchronized, asynchronized.
Asynchronous. Which are only difference?
And the current, sir,
The joules,
this is 50
number
to
of
100
joules
joules.
or energy given is very, very different. Why you give a lesser joules of say 60 to 100 joules only for atrial fibrillation correction? Why you need a 200 joules for ventricular defibrillation correction? What about the muscle mass? Atria has a equal number of muscle like ventricles or lesser muscle mass?
Lesser muscle mass than
Lesser muscle
ventricle.
mass.
So that is the reason why you need a lesser current for conversion of atrial fibrillation by cardioversion. Whereas left ventricular muscle mass is more, so to convert them back all to normal contraction, you require a higher joules or strength energy. Okay, this is another common question they will ask you. Why you use a lower current or lower energy for cardioversion and why you use a higher energy for defibrillation. Okay, right. So only in patients who are hemodynamically unstable and who are within less than 48 hours of onset of atrial fibrillation, you have to do a cardioversion using 60 to 100 joules of energy. What is the pharmacological method of reverting the patient from atrial fibrillation to sinus rhythm? What are the drugs that you can use?
Digoxin, amiodarone.
Xylocaine. You use xylocaine for atrial fibrillation? Xylocaine is indicated only in ventricular tachycardia. First answer is always beta blocker. For atrial fibrillation, you have to give low doses of beta blocker to control the ventricular rate. The second drug of choice is amiodarone. Okay, so these are the two. Third drugs are verapamil and diltiazem, calcium non-dehydropyridine calcium channel blockers. So beta blocker, amiodarone, and diltiazem and verapamil are the drugs that are commonly used for correction of or reversion of atrial fibrillation to sinus rhythm. And hemodynamically unstable patient, early cardioversion is very important. Okay, and if the patient has more than 48 hours of atrial fibrillation, they should be started on anticoagulation. What drugs do you use for anticoagulating a patient who has persistent or permanent atrial fibrillation to prevent a thrombus formation and the consequence of a stroke development?
Warfarin, sir.
Warfarin, will it immediately act?
No, sir.
Ah.
Low molecular weight
Start with
heparin,
a short acting agent. First start with heparin, and while the heparin action is taking effect, you start the patient on warfarin, because warfarin will take at least 72 hours to produce the effect. What should be the INR you should target to achieve these patients who are in persistent or permanent atrial fibrillation?
2.5 to 3, sir.
2 to 3. 2 to 3 is the INR that we should aim for all the patients to prevent the consequences of thrombus and embolism formation. Okay, so these are all the questions that you should be thorough with before going to examination, so that you can answer all these questions. Right, now coming to this lady, you are managing her with the diuretics, and the last drug when all these things fail, you have to give digoxin also. So is digoxin safe in a patient with who is pregnant? Can you administer digoxin to a patient who is pregnant? And if this patient needs anticoagulation because she has developed an episode of atrial fibrillation, how do you anticoagulate a pregnant patient? What are all the guidelines for anticoagulation in a pregnant patient?
Up to 12 weeks, subcutaneous or intravenous unfractionated heparin or low molecular weight heparin, sir, because of organogenesis.
Very good.
12 to 36 weeks will prefer warfarin, sir.
Excellent.
Then after 36, it will be switched over to either subcutaneous or intravenous unfractionated heparin or low molecular weight heparin, sir.
Very good. Very good. Correct answer. But what is the reason you have to again switch over to heparin at the last trimester?
So for INRs,
You know?
Warfarin has a
to
longer
maintain,
duration of action and it has no
Yes.
reversibility.
It takes time for it to reverse, whereas heparin you can use protamine and reverse it because when the patient goes to the last trimester, you expect her to go into labor and deliver at any time. So during that time, if the patient is on warfarin, which is a long-acting drug, the patient is likely to develop hemorrhage, postpartum hemorrhage because of that effect. So during that time, you want a shorter acting drug which can be counteracted if the patient has severe bleeding. Okay. So the initial reason for avoiding warfarin during the first trimester is to prevent drug-induced organogenesis effects to produce anomalies in the fetus. Then from 12 weeks to 36 weeks, it is safer because you want a drug which can be easily administered. Patient will have to take one tablet a day and there is no need for routine injections. So that period it is very ideal to go for warfarin. Again from 36 to 40 weeks, patient can go into labor at any time and during that time if they are on a long-acting drug like warfarin, it may be very difficult to control the bleeding that can happen. So you again switch over to heparin and if needed, you can always counteract the effect. What is the antidote if you are giving low molecular weight heparin? You said if it is unfractioned heparin, we always have protamine, which you can counteract the effect of heparin. But if you prefer to use low molecular weight heparin, what is the antidote? Nowadays, we have factor 10 concentrate available, 10A concentrate is available because low molecular weight heparin affects mainly the action of factor 10A. So you can give factor 10A concentrate and reverse the effect of low molecular weight heparin also. Whereas unfractioned heparin, you can always use protamine and counteract the effect. Okay? So these are all the points that you have to keep. What is Carfred score?
risk stratification in pregnancy in patient with MS.
What are the criteria you take into account? What is the risk that is involved?
So totally 4 criteria, sir. Prior cardiac events such as transient ischemic attack or arrhythmias.
Very good.
Ejection fraction less than 40%, sir.
Okay.
Left heart obstruction comprises of mitral valve area less than 2 centimeters square, aortic valve area less than 1.0 centimeters square, left ventricle outflow tract gradient less than 30 millimeter of mercury,
Very
sir.
good.
And
you said four criteria. Now you mentioned 3 or 4.
3 I mentioned.
Now what is the 4th one? And what is the risk involved? If supposing patient has one.
NYHA class 3 and 4 are presence of cyanosis, sir.
So
If
all
it
the
is
4 things you have to mention.
yes, sir.
Based on that, supposing patient has got out of 4 only one risk factor. What is the percentage of
27%
chances of
mortality
morbidity and mortality?
27%, sir.
7 for all the 4. But one risk factor, it is only about 0 to 0.5%. And as the number of risk factors increase, the percentage of mortality increases. Okay? So that is one of the method of identifying the risk involved. How will you correct or completely cure a patient with matrix stenosis? All the other treatments are only supportive. What is the ultimate treatment for mitral stenosis problem?
Surgical corrections.
Interventional and open procedures.
Balloon valve.
You can dilate, you have to open up the valve and make it normal. That is ultimately the treatment. So that can be achieved by transluminal or transvenous balloon valvuloplasty, or you can go for mitral valve repair. When will you choose balloon valvuloplasty? When will you decide that patient requires only valve replacement? What are the criteria for that?
Sir, for mitral valve replacement, presence of moderate to severe MR, sir, and presence of thrombus in left atrium or left atrial appendage, sir.
Very good.
And badly scarred or calcified mitral valve, sir. These are the indications for mitral valve replacement.
Whereas mitral valvuloplasty, how can it be done? When can it be done? What anesthesia you have to give for balloon valvuloplasty?
The second trimester, sir.
Usually ideal to do it in second trimester. Very good. Where is it done? In the OT or in the cath lab?
Cath lab, sir.
It's done in the cath lab. But what precautions you have to take? When you do a valvuloplasty, is there a possibility that it can overstretch the valve and produce an important complication? What is the complication?
Acute MR, sir.
Acute MR, acute mitral regurgitation. What is the risk of acute mitral regurgitation? Pulmonary edema. Okay. So you must always keep your cardiac OT ready in case there is a overstretching and MR happens. You may have to rush the patient to OT and do a MVR instead of balloon valvuloplasty. May be converted to mitral valve replacement itself. So you must and what anesthesia you give if this is planned for only a mitral balloon valvuloplasty? Does it require full general anesthesia or can it be managed with regular sedation? That's what you do for angiography procedure.
The regular sedation.
It is done under sedation only. It is a mild sedation with an analgesic is sufficient, but you must keep a close monitored anesthesia care. MAC is done under sedation and at the same time keep all precautions ready for emergency open mitral valve replacement also. Okay, right. Supposing it is a bad mitral valve and they plan to do a mitral valve replacement, when is the time to do that?
Second trimester.
If you do second trimester, will the fetus be mature enough? Supposing there is a premature labor happening because of the stress of anesthesia and surgery, will the fetus survive?
No, sir.
So when is the ideal time? Can be planned along with the cesarean delivery. Okay. Any cardiac procedure that you want to do in an open fashion, it is always ideal to do it during the final trimester along with the first you do a cesarean, deliver the baby, and then proceed and go ahead and do with the valve replacement. So that is the ideal time to do the valve replacement surgery. Okay. So these are all the common questions that will be asked in mitral stenosis, and the same principles apply even for patients who are non-pregnant and coming with a for an incidental surgery with a established diagnosis of mitral stenosis. So more or less the same thing. So if this lady, one more thing, if the lady requires a cesarean section with a mitral stenosis diagnosis, what anesthesia you will give for cesarean delivery?
Graded epidural, sir, otherwise combined spinal epidurals.
Combined spinal epidural. Why you want to give a combined spinal epidural? Why not your regular single short spinal as you do for all cesareans?
Sir, local anesthetic will cause sympathetic blockade and precipitous hypotension, which leads to tachycardia, sir,
Very good.
which affects further worsens mitral stenosis, sir.
So, can't you
True.
prevent the vasodilatation or sympathetic blockade and keep the SVR intact?
Yes, sir, by using phenylephrine, sir, and
So you
judicious
can
fluid
use
therapy.
a rhodospinal, and then you can supplement or preserve the SVR by phenylephrine infusion right from the beginning. So that has been accepted, as earlier it was not advocated because of the so-called fixed cardiac output state of mitral stenosis. But later on, a lot of publications have come to say that you can administer 1.5 ml of 5.5% bupivacaine, 37.5 milligram with 20 mics of fentanyl, making a volume of 2 cc, and keep a phenylephrine infusion going right from the beginning to maintain the SVR. What is the advantage? Why can't you use ephedrine for this peripheral vasoconstriction and the SVR maintenance?
It will again increase the heart rate, sir, and worsens the mitral
Ephedrine has got
stenosis.
a dual action, central and peripheral.
Yes.
Central action, it will stimulate the heart and increase the heart rate. So we don't want that increase in heart rate. So phenylephrine will rather produce a reflex bradycardia by increasing the SVR, which is advantageous for the mitral stenosis patient. So phenylephrine is the ideal drug of choice for maintaining the SVR in this patient, and we can use this technique also. But combined spinal epidural, what is the advantage over single short spinal? We practice combined spinal epidural for a patient undergoing cesarean with mitral stenosis. What is the advantage of this combined spinal over a classical single short spinal?
Intrathecal opioid injection to avoid sympathetic blockade along with graded epidural.
I have told you, even with the single shot we are doing it. When you say combined spinal epidural, what is that one major advantage? What is the epidural you are putting in for?
Post-op analgesia.
That is the answer. You can continue
Reduces
post-op
pain.
analgesia with the epidural catheter in situ for 24 to 48 hours. Isn't it? That is the biggest advantage. And you are going to give a very small volume initially for the subarachnoid block. So it will not cause an acute vasodilatation and hypotension also. So these are the two advantages of combined spinal epidural. Right? Okay.
Yes, sir.
So I'll just show a presentation this quickly so that we can